Thank you, Joe. Good morning. It's a pleasure to be here. Thank the World Congress for inviting me. And Joe, I want to thank you for all your leadership here in the management of sepsis and implementation and advocating for the guidelines. It's clear that they make a difference. One of the things perhaps not always covered in the guidelines is the aspect of time to administer antibiotics, and in particular perhaps engage our surgical colleagues. And one of the things I want for you to take home this morning is that early introduction of antibiotics makes a difference, but in particular early source control and removal of the nidus is really vital. Some terminology that we've heard this morning: infection, organism isolated. Is it a colonization? Do we need to start antibiotics? Often in these circumstances, without any other background information and clinical change, we'll wait and see. Patient who has an isolated positive blood culture, transient, maybe inconsequential, another circumstance where repeating the culture, perhaps delaying the start of antibiotics is appropriate. Then we start to get to the more clinically important areas where the patients have developed a systemic inflammatory response syndrome with these clinical signs, and in pediatrics, others such as glucose instability, apnea. This is the time to start thinking about source, and certainly the time to start thinking about introduction of antibiotics. Because as patients progress through to the sepsis, severe sepsis, and septic shock, things are rapidly getting out of control. And to try and expect antibiotics or source control to reverse this, certainly by themselves, is perhaps optimistic. Because remember that most sepsis starts locally. It's a local response to whatever the organism, with creation of cell wall receptor complexes, usually with some sort of lipopolysaccharide in this particular cartoon, an activation of a lot of transcriptional factors regulating the expression of inflammatory genes, and then the release of cytokines, chemokines, adhesion molecules, and others that starts to amplify the entire inflammatory response. So local control is very important to prevent this amplifying into this, where you start to get inflammation activated cascades, particularly the coagulation cascades with the production of thrombin, the decrease in fibrinolysis, and the risk for intravascular thrombosis and then end organ injury. And thrombin is a particularly bad player here because it will amplify further aspects of inflammation with cytokine release, endothelial binding and activation, and leukocyte activation. And of course, the problem with all of this is the endothelial injury that we see with the rolling adhesion migration of leukocytes contributing to the tissue injury. So to stop these cascades, early intervention is clearly very important. About 11 to 12 out of 100 ICU admissions are patients with sepsis of some sort. This comes from a study published in the Critical Care and Resuscitation last year by French. The sites, these were mainly community-acquired infections, mostly pulmonary, abdominal, and urosepsis. I'm going to talk primarily about these, therefore. Interestingly, about 60% of the cases the organism was could be identified, but in 40% no identification, which obviously raises concerns about what type of antibiotics and when to introduce them. Most, or more than 50%, were gram-positive organisms, 35 to 40 gram-negative. And it's particularly in the United States and in my area of Boston, an increasing incidence within the community of MRSA. So that's changed the way in which we think about the types of antibiotics we institute. Now, the early antimicrobial therapy reported by some of our infectious disease colleagues, and if you look at their textbooks, they'll come to these sort of conclusions, that there's this patient who relatively late administration of antibiotics, where within 48 hours you've got a blood culture result, you've got a known organism and susceptibility. You can quantitate it with perhaps either colony-forming units or MIC, and target with appropriate antibiotics. This is clearly too long to wait. Then there's the group that within hours of presentation, arbitrarily perhaps 4 hours, where you do a rule-out. And the difference there is, are they community acquired or hospital acquired? Should you use broad spectrum cover? At least in a number of infectious disease textbooks, appropriate antimicrobial cover at least 24 hours prior to identification improves survival is the statement that is fairly common. And from what we've heard already this morning, that's still way too late. This study was presented by of Sebat, was presented by Victor and a multidisciplinary community hospital program for early and rapid resuscitation of shock. Now, these are non-trauma patients, and these are the early interventions. And as Victor said, early arrival of the intensivist, early admission to the ICU, administration of fluid, all had a significant impact on outcome. This is a shock program that was effective and worked. They included within that an early introduction of antibiotics, and they decreased it from 6 hours to 4 hours by introducing this shock program. That did not come out as a significant variable in terms of outcome, but there are so many different variables to include in here to actually tease one piece out of it and say that definitively makes a difference over others is difficult. But nevertheless, this was an important component to their shock program. And courtesy of Joe, this slide demonstrates that this group is going to report a significant decline in their mortality associated with sepsis bundle, implementation of sepsis bundle, from 6 hours down to 1.5 hours, which is a really remarkable improvement. So where do antibiotics fit within that bundle? I think one study that perhaps helps outline that a little bit is this study by Kumar, published in Critical Care Medicine, where they looked at the clinical indication for the introduction of antibiotics was hypotension. So a relatively late clinical sign in the course, but unfortunately often the one that our patients may present with. So looked at hypotension before the initiation of effective antimicrobial therapy. And this is the number of hours of hypotension, time from hypotension onset, and this is the number of patients. And black here is survival, and the grey are the cumulative effect. So that if you decrease as the time for administration of antibiotics increased, then the survival fraction also increased. So that 80% of patients survived if they received antibiotics within the first hour of presenting with hypotension. And that for each hour without antibiotics, the mortality increased by 7.6%. I think this data was out of Canada, 14 studies, 14 centres. It was a retrospective analysis of a large number of patients. So with all those limitations of a study design, I think they were able to demonstrate that the earlier you get antibiotics in, it does make a difference. And I think they had sufficient numbers of patients to actually tease this out. And one of the problems is, what is the marker of sepsis? If we're going to rely on a clinical sign and a hypotension, then perhaps the cascades of events have already set themselves in motion. Laboratory data may help us, the white cell response, altered coagulation, indices of tissue perfusion. But other markers have been recommended, although their prognostic capability is of perhaps some question. In our institution, we rely on ESR predominantly, but it's a late predictive value. Perhaps a more early predictive value of sepsis is procalcitonin, and while not available in the States, is certainly, I think, has the potential to help as an early diagnostic marker. And these are two studies that confirm that, looking at receiver operated curves for procalcitonin versus CRP, and that you can see that for procalcitonin here at 0.99 and 0.91, very strong indicators perhaps of early sepsis. Whether or not they're able to assess disease severity is another question. So the elimination of pathogens, keep re-emphasizing, appropriate microbial cover as early as possible. And it's related to and will improve clinical outcome. The type of organism perhaps has an influence. Fungal infections, the survival rate for fungal sepsis is lower than for bacterial mediated sepsis. And interestingly, those patients that have no identified pathogen, they have, in fact, the highest survival rate. But the type of antibiotic that you need to institute is really going to be dependent on the tissue penetration and to produce the least side effects. And we have known targets, or we often go on a search and destroy mission where we don't really know the particular organism and sometimes the source. But it's a critical determination to make sure you have an adequate microbial concentration. We don't routinely get this given to us. We have to ask our laboratory now to provide some sort of quantitative data for us when we're choosing our antibiotics. They do perform it, but they don't routinely put it in our chart. Same with colony-forming units. We can ask for quantitative data, but we're often left with qualitative data. So the choice of antimicrobial agent, we can try and identify the organism. Obviously, gram stain will help. Other perhaps methods that will take a period of time from hours to days, but delayed in terms of helping you make that decision. And then there are host factors one needs to consider, such as the age of the patient, their underlying organ function, some genetic factors, and their site of infection, which will determine the penetration of a particular antibiotic. But often you're left relying on statistics. And this is another very important point. I will show you an algorithm that we use for particular antibiotic administration in our institution, but it's very Boston Children's Hospital specific. We heard this morning a wonderful talk about sepsis in India and the management. And clearly, what we use in Boston is going to be different to the needs in other parts of the world. And I think it's very important that you know your own statistics and apply your own antibiotic guidelines according to your environment. And they would be determined by whether or not it's community or hospital acquired, whether the patient's immunocompromised, whether it's hospital acquired. Interestingly, in one study, 45% of hospital-acquired infections were treated inappropriately with the inappropriate antibiotic. And then an assessment of susceptibility. The tissue concentration is very important and affected by drug kinetics. Protein binding has an important effect in terms of whether or not the drug will penetrate into interstitial fluid and lymph. Lipid solubility is important as to whether or not it will penetrate membranes, particularly blood-brain barrier. And then biliary excretion and concentration will have an effect, obviously, in patients with GI infection and particularly cholangitis. A number of host factors that are important, such as whether or not the antibiotic will actually penetrate the area locally, and that includes vegetations in my own area in a cardiac intensive care environment, but also bone and other devitalized tissue. Whether the antibiotic is going to be inactivated because of the pH of the material or the purulent material that's in the source, and whether there's a foreign body, in particularly prostheses that serve as a nidus for adherence and form biofilms that will prevent either the penetration of the antibiotic or a nidus for ongoing microbial concentration. Antimicrobial combinations, certainly broad spectrum cover for any concern regarding polymicrobial contamination such as GI sepsis, in the immunocompromised patient, and perhaps in the hospital-acquired and ICU setting. In our environment, we will often start gram-negative, gram-positive cover in our patients within the ICU setting as patients start to develop signs of sepsis syndrome. And the other question to remember is that antimicrobial combinations, whether or not they're synergistic, and it may be very important for resistant organisms, may be very important to affect adequate tissue penetration, such as endocarditis, for Staph aureus species, and for Pseudomonas species as well. These combinations have proven to be very important to ensure adequate tissue penetration. And synergism may also be necessary because the antibiotics inhibit sequential steps, such as the classic example of that, of course, is Bactrim. This is an algorithm that we use in Boston. As I said, I'm not going to go through this. This is something that I think is applicable to us in our environment. You need to develop your own guidelines based on your environment and your statistics, bacteria statistics. Source control, known suspects, we have clinical targets to go for. Abdominal sepsis, urosepsis perhaps, empyema, those types of targets we can deal with. Then there are patients who have persistent sepsis or develop new sepsis as part of their treatment, and we're not quite sure where they're coming from, and these are some of the sources that need to be considered. Intravascular catheters, infected thrombus, endocarditis, osteomyelitis, sinusitis. I put all those 5 down because in the last 6 months we've had to deal with all of these in our intensive care unit in a patient where we've been treating with antibiotics cannot clear either their clinical signs or clear their cultures. And the principles of Nidus removal are to drain, and it can be either surgically or percutaneous, to debride devitalized tissue, and to remove foreign bodies. It's standard, straightforward, and engaging the surgeons in this decision-making is extremely important, and you need to engage them early. This study by Barry comes from the Prowess study looking at activated protein C. He looked at the benefits and risk of activated protein C in surgical patients with severe sepsis. Now, buried within this here, and I thank Joe for pointing this out to me, is that if you look at their source control, 28-day source control, that those patients that had inadequate source control, whether it be in the activated protein C arm or in the control arm, had a much higher mortality. So, it's very important to remove the source of ongoing sepsis in these patients, in addition to everything else that we talk about. And when the source is removed, the mortality is greatly decreased. So adequate source removal, you've now got a survival rate of over 90%, as opposed to less than 10% in patients where there was inadequate source removal. Now, the surgical débridement and excision depends on whether it's confined and you've got demarcated tissue, whether there's rapidly evolving ischemia and necrotizing fasciitis. I think in all of these, there's a good indication to go ahead and do a surgical approach to the sepsis. But the critical element in source control is to remove the locus for unopposed microbial growth and unopposed activation of the sepsis cascades. If you have a confined abscess, then local host inflammatory response will wall it off. You'll have a fibrin and a fibrous capsule develop. And it'd be very hard to penetrate and sterilize with antibiotics. So therapeutic drainage to minimize contamination of uninfected tissue and to break the sepsis cascades are very important. Will be the source of ongoing fever, leukocytosis, and pain. Drainage in a confined abscess could be surgical or percutaneous. How to diagnose the source and how to drain it, there's some discussion as to differences, but CT with contrast is superior to ultrasound in most studies in terms of being able to accurately target a confined abscess. If it's unconfined, such as necrotizing fasciitis, early surgical removal of that tissue is very important. It may be extremely disfiguring, but unless you remove that tissue and control it, it's going to be ongoing. Perhaps a laparotomy if there is no well-defined collection, if there is progressive ischemia and likelihood of infarcted bowel, such as necrotizing enterocolitis that I see in my population of patients, and if there is the risk for ongoing contamination from perforated viscus. Obviously, the risks here for the surgeon are bleeding, the development of fistulae, wound infection, and not to dismiss, of course, the fact that these patients are usually very sick on substantial inotrope and hemodynamic support, and they go to the operating room in poor shape. However, in these circumstances, it is very important to go in and control the source. Otherwise, you will not see a turnaround in their overall clinical condition. Some aspects of intra-abdominal infection, whether to do percutaneous drainage or operative, to some extent it's dependent on the source and the patient. If it's confined abscess, perhaps draining, stabilizing, and then an exploratory laparotomy. On the other hand, if the patient's deteriorating rapidly with ischemic bowel, you need to get rid of that as soon as possible, and just placing a drain in that abdomen is not going to solve the problem. Some other surgical aspects: continuous peritoneal lavage, no real proven benefit. A second look is certainly recommended in patients where there is questionable intestinal viability. Laparostomy, leaving the abdomen open. We use that in patients where ventilation is particularly going to be compromised, although obviously we're raising a whole series of additional problems on top of that. There is no real benefit over re-laparotomy on demand for a planned or staged abdominal approach at 24 or some arbitrary hours afterwards, 24 to 72 hours, other than the patient who you're going to do a second look because of the concerns for intestinal viability. And there is no data that I can really determine that empirical or blind laparotomy improves outcome in patients with severe sepsis syndrome. So the removal of the foreign body is very important, but you need to assess your risk versus the benefit. For intravascular catheters, urinary catheters that form biofilms of microbial colonies, early recognition and removal makes sense, although I'm sure we've all been in circumstances where we've got a patient with limited intravenous access, they've lost other vessels from thrombosis because they've had previous catheters, and now you've got an infected central line, patient's sick. You're going to try and treat through, and you need to make a judgment as to how to actually, whether or not that's in the patient's best interest. Another tube that is often in our, we have discussions about is whether or not to replace an endotracheal tube, whether a biofilm around that is contributing to ongoing tracheitis, or whether there is another source such as sinusitis. We have a high incidence of nasal endotracheal tubes in our unit. We have a large percentage of neonates and infants, and there are circumstances where we have persistent sepsis, we just cannot clear it, and simply changing from a nasal to an oral tube allows the sinuses to drain and makes a difference. The newborn has sinuses. They're very small. They're not air-filled. They're filled with bone marrow. They do become infected. And then finally, should we remove devices? And that's where, once again, the risk-benefit has to be weighed. But in my own experience with pacemakers, for instance, unless you take them out, you're not going to clear them. And by taking them out, it means explaining completely the whole system, irrigating the pocket, and a prolonged course of antibiotics before you can then re-implant the pacemaker, which means, of course, the patient then has to have epicardial leads, temporary wires placed so that you can continue to pace this patient during the period of time that the pacemaker is explanted. Obviously, it raises their level of treatment considerably, but unless you do that and make those steps and make that commitment, you will not clear the infection. So I want to finish by a summary that the response to sepsis is associated with multiple multi-system derangements. There are variable manifestations and outcomes that we've mentioned, but the early interventions remain essential. That includes the resuscitation bundles that are goal-directed, but time-sensitive antibiotics and time-sensitive source control remains key. Thanks for your attention.